I spent many years trying to become a good clinician and to develop good services and to conduct research so we could put our treatments on a much stronger evidence-based footing. But then I think there's a responsibility for people like me then to try to translate what we know and what is working into the real world. And mental health is very much the poor cousin in healthcare. And the people with mental illness and mental ill health, especially young people, are getting a very raw deal. Only 16% of people in Australia receive minimally adequate evidence-based care for depression and anxiety, and that wouldn't be tolerated in cancer. So this is why we have to become activists, I suppose. We have to communicate to the public and explain to the public how they're missing out here, and also we have to engage with politicians so that we can get support for solutions to these problems, and that is sort of working to some degree. That translation and activism, but we need more people in the mental health field to do that. And I'm sure there are many psychiatrists in many countries very active in that, like, for example, Norman Sartorius. He's been doing that for many years. But in cancer and heart disease, there are hundreds of people doing that, whereas in psychiatry we need a few reinforcements. I saw a presentation from Adocare, who analysed from the perspective of the EU the situation in Western Europe, and it was pretty dismal. It was pretty dismal in terms of access and quality of care, and that is also true of mental health more widely. Something like 10% of people in the OECD with depression, only 10% get evidence-based care. But it's worse for young people. They are if mental health is the poor cousin, the young people are the poorest cousins. If you look at those figures, you see this big surge of incidence and high prevalence right across particularly the late adolescent, early adult period, and that's when the access is worst. Swaran Singh showed in the TRACK study that it's the worst possible time to try to get access to the system in late adolescence or early adulthood. So obviously there's a massive problem, and even if all you did was improve access to care that might actually be okay, that would be a big improvement. But I also think the quality of care needs to be improved and made more appropriate in terms of skills and effectiveness for this age group. And that's something, as you say, with the triple P example, you could test whether you could improve that too. Treating this age group requires a fair bit of skill and talent and commitment too. So it's not for everybody, and it's much more challenging in many ways than it is treating, say, 35 and 45-year-olds. So it does require a different type of mindset, and also, I think, a team-based approach, because there are a number of aspects that need to be helped with. So it's not something you can do, in an isolated office. I don't think.